Okay, very good afternoon, everyone. It's a pity that I'm not a attend this. I hope that you had a good lunch earlier. So I'm Louis. I'm tasked with giving you the topic of narrow complex tachycardia made easy. So I hope I present myself well for this topic. So without further ado, I will just proceed. So okay, can you hear me now?
Yes, Dr. Lewis, we can hear you.
Right, okay. So I'll just begin. So I'll give you an overview of the narrow complex tachycardia. So basically, the basic definition of tachyarrhythmia is any rate more than 100 beats per minute. And if the QRS duration is less than 120, and we term it as narrow complex tachycardia, and of course, it's further classified into whether it is regular or irregular. So we're just going over some basics here. And so we have our tachyarrhythmia framework here. So this is just a major overview of what we're going to talk about today. So generally, we have both wide and narrow complex, which the wide complex will be covered by the next speaker. And of course, we have our narrow complex regular and narrow complex irregular rhythm. So moving on to mechanisms of narrow complex tachycardia, we have generally three basic mechanisms for all tachycardia. And the most common ones are those which are re-entry, and it can be micro re-entry or macro re-entry. So when we talk about the most common re-entry tachycardia, which is AV-NRT, it is basically a mechanism of a micro re-entry over the AV node. And we also have a macro re-entry tachycardia, which is the AVRT, comprising of using two circuits, which is the AV node and also the accessory pathway. And we have an automatic mechanism of tachycardia, generally our atrial tachycardia, where it is firing from a single focus, or we have a macro re-entry of either the right atrium or the left atrium, causing an atrial flutter. For irregular narrow complex, we have most commonly atrial fibrillation, where it is irregular discharges from multiple places in the atrium, most commonly from the pulmonary veins. And of course, multifocal atrial tachycardia, which is something like atrial tachycardia, but it is from multiple focus. So the first step to identify and recognize the different types of tachyarrhythmia is by good history and how the patient present to you. So generally, when we talk about how the patient's symptoms and how the disease progress, and when we ask about the patients regarding the duration and the symptom of onset, usually a long history and patients which involves a younger group usually points towards a re-entry mechanism, either AVNRT or AVRT. This gives you a bit more clue. If it's a recurring tachycardia more than 3 years, by some people, that could be more likely to be an SVT. If patients are of an older age group and have previous history of ischemia and presenting to you with a wide complex tachycardia, and the positive predictive value for VT is higher than rather than a SVT with emergency. So these are some things which you can keep in mind the next time you see ECG straight with a tachycardia. And when we look at ECG, it is preferably a 12 lead. I'm sure you have received referrals from people with only a single lead 2 and single lead 1 and ask you what's the diagnosis. That could be very, very misleading, and it may actually be misinterpreted as well. So it would be best if you can have a 12 lead ECG to further study and assess what is the rhythm like. And the most important part of a tachy ECG is actually the initiation of the tachycardia and the termination of the tachycardia. So if you can get that, it gives you a very important clue of what is actually the underlying diagnosis. And as all tachyarrhythmia ECG, it is important to assess what is the VA relationship, or in ECG terms, what is R to P relationship, meaning that how many QRS to how many P waves on the ECG. And logically thinking, if there are more QRS than the P waves, then the diagnosis is likely to be ventricular tachycardia. If the P waves and the QRS is in a 1-to-1 relationship pattern, then it can be sinus tachycardia or or supraventricular tachycardia, which is AT, AVRT, or AVNRT, which is the usual suspects. And if you have more P waves than your R waves, then likely it is something coming from the atrium, which is your atrial tachycardia and atrial flutter. But of course, there are some very rare cases where you have AVNRT, which is a 2-to-1. I think Dr. Xiao had mentioned it earlier, 1P to 2 QRS. That is rather rare as well, so I think we'll leave that later. So some important tachy concepts is that when you look at the ECG and you see an initiation of the tachycardia, and if there is a sudden prolongation of the PR interval after an atrial ectopic which comes earlier than the next P wave, that initiation actually suggests AVNRT, and I will show you an example later. And if you see the termination of the tachycardia with a retrograde P wave, generally we can rule out atrial tachycardia because that is very unlikely as well. I have an example later as well. And if you look at a Holter, I'm sure all of you ordered for your patients investigating for tachycardia. So if you see a warm up or cool down phenomenon, that actually suggests atrial tachycardia. What I mean by this is, if you look at this Holter tracing, so you can see this baseline sinus rhythm here, and this sinus rhythm actually sort of accelerates onto a tachycardia episode, which is rather regular. And when it comes to this part, instead of terminating abruptly, it actually slows down. So this actually is a sort of like this part is a warm up, and this part is a cool down phenomenon, and this actually suggests atrial tachycardia. So if the next time you see a Holter and you see this, so atrial tachycardia should be part of a differential diagnosis, and of course you can look at the 12-lead ECG for the ectopic P wave morphology. So further evaluation, of course, we will ask all our patients to go for a transthoracic echo at the very least to rule out structural heart disease, and we can subject the patient for Holter monitoring, portable cardiac monitor, and implantable loop recorder. So these are generally for patients who have intermittent symptoms, say once in a week or once in every 2 weeks or a month. So ordering a whole 24-hour Holter would be more or less futile for them. Not to say it's completely useless, because most of the time they are asymptomatic. So a portable cardiac monitor can really help you to diagnose this patient better. So here, nowadays we have a lot of technology. We have the Apple Watch, we have Cardia Mobile, we have this thing called a 1-week portable cardiac monitor with patch on to the patient, generally measure lead 2, and we have an implantable cardiac monitor subcutaneously to monitor patient up to 3 years, whether investigating for tachyarrhythmia or syncope, or for whatever reason the patient needs it for. So when we talk about narrow complex tachycardia, generally it's divided into regular and irregular. I'm giving a new concept of measuring the R to P interval. So if the narrow complex tachycardia is irregular, then 99% of the time you can bank your question, your answer on atrial fibrillations. Other differential diagnoses are rather rare. If it's regular, then you look at the AV relationship. If the A is more than the V, which is the P wave more than the R wave, then it is an atrial tachyarrhythmia, which can be atrial flutter or atrial tachycardia. If the A and V is into a 1-to-1 ratio, then you look at the R to P interval. So what is this RP interval? So if you look at this chart here, after the QRS, the R wave, if the P wave is less than 50% of the next QRS, it is a short R to P interval. If the P wave is near to the next QRS, or more than 50% of this R interval, we term this as a long RP interval. So for long RP interval, we have differential diagnosis, which is listed here: atypical AVNRT, AT, junctional, or sinus tachycardia. If the short R to P, then most likely it is autodromic AVRT, or if the P wave is really near to the QRS, it can be typical AVNRT, junctional, ectopic tachycardia, or AT with a first degree AV block. We'll go through some case examples so that you can, sort of practice these algorithms. So we have our first case, a 35-year-old lady who has a known medical illness, complaining of recurrent palpitation since 2015. No specific triggering factors, lasting for 5 to 10 minutes, no angina, no syncope. Presented to ED with palpitation again. So I think this is a very common ECG which all of you have definitely seen before. So I'm not going to put any poll up. I'm just going to go through the ECG with all of you here. So this is generally a narrow complex tachycardia. You can see the QRS duration is less than 120 millisecond here. So narrow complex with sort of a normal axis. So as we have mentioned earlier, if you do not have the initiation or the termination of tachycardia, you look at the QRS and the P wave relationship. So it's more like a P wave hunting exercise here. So you go through the chest leads and you go through the limb leads to look for P wave. And here, I think the P wave is most clearly seen in the inferior leads, where you can see after the QRS, there's this small negative bump here, which is very peculiar for a QRS complex. So I would say this is probably the P wave here, which is negative over AVF, negative over lead 3 and lead 2. And if we say that is the P wave negative, then this most likely would be a P wave right after the QRS here, and which is a positive bump. So we call this a pseudo R wave. So to put things into context, this is what we call as a short RP tachycardia, as this is less than 50% of the of the next QRS, and sort of like A on B because it's so near, right? So likelihood the diagnosis is typical AV and RT. And of course, if you are still not convinced for narrow complex tachycardia, I'm sure the previous speaker have talked to you about the management of it. So the next thing, of course, what you will do is you give adenosine. So when you give adenosine, what happens to a tachycardia is it will respond to the AV nodal blocking effect of adenosine. So once you block the AV node, you can see the tachycardia just terminates over here, probably with a retrograde P wave here. So if it's a retrograde P wave, it makes atrial tachycardia very unlikely, because if it's an atrial tachycardia and you give an AV nodal blocking agent, the atrial tachycardia should be marching on as well. So there will be continuous P wave. For this to happen, it needs to have the AV node block and also the atrial tachycardia, which terminates abruptly after adenosine, which makes it very, very rare for two rare things to happen at one time. So likelihood of this is actually diagnostic of AV and RT. So the response to adenosine is actually very predictable, and it can give you the clue to the underlying diagnosis which you are facing. So as we have mentioned earlier, if the tachycardia terminates with adenosine with retrograde P, likelihood is AV and RT. It could terminate for autodromic AVRT as well, because it is AV node dependent with a one-to-one relationship. If you give adenosine for atrial tachycardia, what you will see is a P wave marching on with resumption of sinus tachycardia or resumption of atrial tachycardia after the adenosine effect wears off. And if it's atrial flutter, usually you will see the flutter wave marching on as well, which I will show you an example later. So keep moving on to some basics of how an AV nodal re-entry tachycardia happens. So basically it is tachycardia involving a re-entry circuit of the AV node. So for this to happen, you need the patient to have two pathways in the AV node. One namely the slow pathway and one namely the fast pathway. So in normal sinus rhythm, your impulse comes from the SA node going down to the AV node, and it will go down the fast pathway and depolarizing the ventricle, causing a normal PR interval and a normal QRS complex here. So usually this impulse will go up to the slow pathway retrogradely and blocks the slow pathway impulse anterogradely. So this is our normal sinus rhythm response. But however, when there is a premature beat which comes in either from the SA node or from another focus, it travels to the AV node, and at that point, the fast pathway may still be refractory. It cannot accommodate another antegrade conduction. So this premature beat will actually conduct down the slow pathway, depolarizing the ventricle, and at the same time going up the fast pathway, causing a re-entry circuit there. And that is how an AV energy perpetuates. And this needs a very exact timing every single time. So to put things into context, this is on ECG. Yeah? So if you have a sinus rhythm here, and there is a PAC which comes earlier, and you can see there is a prolonged PR interval there, and there is a narrow complex tachycardia. So if you look at the ladder diagram, what this PAC does is, once the PAC comes in, the fast pathway is actually blocked here, which is normally used for normal conduction because it's refractory, right? So the PAC gets blocked in the fast pathway, and it goes down the slow pathway, depolarizing the ventricle, and make a U-turn and go back up and depolarizing the atrium, and this persists. So we call this as a slow, fast AVNRT. So this is another example in sinus rhythm, utilizing the fast pathway going down for normal conduction, and in tachycardia, using the slow pathway to go down, fast pathway to go up, causing a pseudo R here. So this is exactly what happened in our initial ECG. So I hope all of you get this concept right. And for management, I think the previous speaker have already mentioned about the management acutely for AVNRT. I'm just going to focus more on the chronic therapy. So if the patient has already been treated, let's say you have an SVT or AVNRT patient given adenosine and has recovered, but however coming in with recurrent symptom. So one way is it's a class 1 indication EAC for catheter ablation, and however, if ablation is not desirable or is not feasible in your center, you can put the patient either on a beta blocker or calcium channel blocker if the the ejection fraction is normal. So generally in the EP lab, what we target for AVNRT ablation is the slow pathway. We don't ablate the fast pathway because the fast pathway is used for normal conduction. So by ablating the slow pathway, generally we are actually terminating the circuit so that there will be no more re-entry. And this can actually be targeted with either fluoroscopy or with 3D imaging. So that is what we do if we will refer a case for AVNRT ablation. So moving on to case 2, we have a 65-year-old lady with known medical illness who complained of sudden palpitation. So forgive me for this blurrish ECG, but generally what we see here is also another narrow complex tachycardia, which we can't really see where is the P wave here, but however, again, in the inferior leads, you clearly can see there is a bump there, which looks like it is probably negative P wave here. And if we say that is the P wave, then there is probably a P wave here as well. Otherwise, you can't really see any other P wave. So generally what I can gather from this ECG is a narrow complex tachycardia, which is a short RP tachycardia here with a normal axis. And this patient came in when she was unstable, so she was cardioverted. So when the patient is cardioverted, it makes things really easy here, because when you look at the sinus ECG for this patient, you can clearly see there is an initial slurring of the QRS. So this initial slurring here is termed as delta wave, and this patient actually has a Wolff-Parkinson-White syndrome, which makes the previous ECG an autodromic tachycardia because it's narrow complex. So that involves the tachycardia using the AV node as an antegrade pathway and the accessory pathway as the retrograde pathway. So a little more in depth into the localization of accessory pathway just by ECG, we have this small little nice algorithm here, where if you look at the delta wave 1D1, and if that's negative, it tells us that this pathway is actually is over the right side, which is tricuspid annulus. Then we count the number of positive delta waves in the inferior leads, and in this case, there is one positive wave in the inferior leads, and so sort of this area. And if V3 is negative, which is in our case, this patient has most likely has a right posterolateral pathway, which is proven in this case during ablation. So a bit of theory here. So AVRT generally involves two circuits. One is the AV node and another is the accessory pathway. And we call the tachycardia as autodromic when the tachycardia utilizes the AV node as the antegrade pathway and the accessory pathway as the retrograde. So sort of like in a clockwise fashion, depending on whether the pathway is left-sided or right-sided pathway. And we term it as an antidromic AVRT when the tachycardia uses the accessory pathway as the antegrade limb and using the AV node as a retrograde limb. So this will actually cause a broad complex tachycardia, sort of like what you see in pre-excited AF. So for management as well, it doesn't deviate much from what the previous speaker has mentioned. In unstable patients, we do synchronous cardioversion. In stable patient, vagal maneuver can be attempted. In autodromic AVRT only, adenosine can be can actually be attempted as well. But however, if it's antidromic AVRT, which means that with the impulse goes down from the accessory pathway, we don't recommend adenosine. It is actually harmful for the patient. And of course, when drug therapy fails, cardioversion should be attempted. And for chronic therapy, patients who are symptomatic, recurrent admissions for AVRT catheter ablation should be recommended. And beta blockers and flecainide can be used for patients with AVRT if there are no pre-excitations on ECG. So a bit on flecainide if it's available in your center. From previous studies, we know that flecainide blocks the accessory pathway conduction in around 50% of the cases. So it's actually rather effective in half the patients that we prescribe flecainide with. But however, it should be co-administered with beta blockers, as it reduces the risk of a one-to-one rapidly conducting atrial flutter down the AV node. So using flecainide alone without a beta blocker is not recommended. And I'm sure in your practice you have seen patients with delta waves, but it's asymptomatic. And in this group of patients, we recommend that they should be referred for EP study to risk stratify the patient. So some risk factor for sudden death with patients with asymptomatic WPW is that if the patient is of a young age, if the patient has got a shortest pre-excited RR interval of less than 250 milliseconds, on TTE there is a presence of a structural heart disease. So these patients should be ablated even though they are asymptomatic. So this is what it looks like for EP study on fluoroscopy. So we can bring the patient in for fluoroscopy. And this is one of the cases which we did a 3D ablation of accessory pathway. I think this is left-sided pathway. So we can see here on ECG, there is the V1 delta wave is positive. So according to the algorithm earlier, V1 positive means it's off from the mitral annulus. So, and this patient was targeted over the mitral annulus and was ablated here. You can see the disappearance of delta waves here. On the next bit, it is a narrow complex. So this is a definitive treatment for all AVRT cases. So moving on to the next case, we have a 44-year-old with a history of syncope preceded with palpitation. So what we have here is a regular complex tachycardia, narrow complex. It's almost 120 milliseconds. So again, it is a P wave hunting exercise. We hunt for the P waves. Here on the inferior lid, differing from the previous ECG, it's not really clearly seen here. We are unsure if there's one or two P waves. However, on V1, you can clearly see these two are of similar morphology. So likely this is a P wave and that's a P wave too. So it's a 2 P wave to 1 QRSs. If these two are the P wave, we move back to the inferior leads, which means that these two might be the P wave too, but it's not so clearly seen. So what we are dealing here is probably a long R to P. So long RP tachycardia. So it can be atrial tachycardia, atypical aberrancy, or junctional. But seeing that there is 2 P wave to 1 QRS, it makes the rest very unlikely, and this is a case of atrial tachycardia. So this case, when it was referred to me, patient was unstable, and we actually gave a cardioversion, and it returned to sinus rhythm. So there is actually a P wave algorithm that we can actually sort of guesstimate where the ectopic tachycardia is. As you can see, the P wave morphology in V1 is positive and the P wave morphology in the inferior leads are negative. So if that's the case, here it is probably in the left atrium, somewhere inferior. But however, all these are only for patients without a dilated cardiomyopathy or with no structural heart disease. If the patient has a dilated heart, so all these algorithms are slightly unreliable. And you can see the sinus rhythm ECG, the P wave here, from positive it became negative. Here from negative became positive. This became a normal sinus rhythm ECG. I do not have the termination ECG here. If we would have given adenosine for the previous ECG, likely what we will see is this, where there will be a termination of QRSs, and there will be a marching on the P waves here. So that would be diagnostic of atrial tachycardia, right? So, okay, then our next case, something similar to our previous one. I'm sure at one glance you will see this ECG, narrow complex. going at a rate of probably 100 beats per minute. But there is a very obvious seesaw pattern here. So I'm sure most of you know this is a flutter wave. So these flutter waves are actually negatives in inferior leads and positive in V1. So this is actually atrial flutter, and most of the time, as you see, this ECG is right-sided, going in a counterclockwise direction. So why do I say counterclockwise? So atrial flutter generally is a macro reentrant involving either the right atrium or the left atrium. So when we say it's typical atrial flutter, it means that it is CTI dependent, which means cavo-tricuspid isthmus dependent, utilizing most of the time right atrium. And it can be counterclockwise or clockwise. So if it's counterclockwise, you will see the flutter waves negative in the inferior leads and positive over V1. And if it's clockwise direction, which is reverse typical flutter, you will see the flutter waves positive over 2,3 AVF and negative over V1. So in our case, it's negative in 2,3 AVF and positive in V1, which makes this a typical counterclockwise flutter, which most likely is CTI dependent, but that only can be diagnosed in the lab. So for general management of atrial tachycardia or atrial flutter, acutely, if the patient is unstable, DCCV, no questions asked, and adenosine can be helpful in the diagnosis of nature of or underlying rhythm. Acute therapy includes beta blocker or amiodarone. Chronic therapy to slow down the rate, you can actually give beta blockers, or for antiarrhythmics, you can probably give flecainide or amiodarone. If you have a patient who is diagnosed as atrial flutter, you should anticoagulate them, like how you calculate a chart bar score for atrial fibrillation. And if the patient is symptomatic, you can schedule them for elective cardioversion after adequate anticoagulation for at least 3 to 4 weeks. And if the patient is having recurrent symptoms of failed medical therapy, they should be referred for catheter ablation. And some even think that the moment you diagnose a patient with atrial flutter, they should be referred for catheter ablation as well. So once you have exhausted all these options, the last resort is actually what we call as ablate and pace, which this is more of like a palliative kind of treatment, where you put the patient on a CRT or biventricular pacing or a conduction system pacing with AV node. This is generally not used unless you ran out of options. So this is sort of a showcase of what we do in the lab. So what you can see here is the right atrium with the inferior vena cava, and this is a tricuspid annulus or tricuspid valve here. And you can see these things moving here. This is actually the tachycardia wavefront of the atrial flutter, and you can see the ECG at the bottom screen here, where it is a sort of a 2-to-1 flutter. So you have 2 flutter waves to 1 QRS. And this, you can see that this wavefront is going around the tricuspid annulus in a counterclockwise manner. So this is actually a typical right-sided CTI dependent, cavo-tricuspid isthmus dependent counterclockwise flutter. So what we have done for this patient, basically we ablate the CTI, we ablate the cavo-tricuspid isthmus by drawing an ablation line there connecting the inferior vena cava to the tricuspid annulus. So what that does is that it actually prevents the tachycardia from re-entering. So we cut off the circuit. So you can see here, so there is tachycardia, atrial flutter here, which terminates after the last ablation and sinus rhythm resumes. So I think that's the last case here. So in summary, I think before you even see the ECG, a very good history can give us a clue to the underlying diagnosis. And don't only rely on a single lead ECG. Look for a 12 lead and look for what's a VA or RP relationship. And if possible, look for the initiation and termination of the tachycardia, which gives you a lot of information and probably can give you a definitive diagnosis in most cases. And if you are still unsure, you can give adenosine to uncover the underlying rhythm. And if the patient is unstable, don't think about the diagnosis. Just cardiovert the patient and reassess the ECG later. And I think that's it. Thank you very much for your attention.